Okay, welcome to another MedCram lecture. We're going to get in right to where we left off with the EKG. We're going to talk about the P wave, and we're going to talk about actually all the waves, but we'll start with the P wave first. And as we discussed, the P wave is the first wave, and it starts off in the sinoatrial node. And it's going to start off up here in the SA node, which has the most automaticity. So with this conduction and with this depolarization, it's going to basically spread along these fibers, which are modified myocardiocytes, especially here along Bachmann's bundle, which will then spread it over to go to the left atrium. And then, of course, over here, where it already is, in the right atrium. And as this spreads, this electrical conduction is going to cause depolarization to occur all throughout both atria. Both the left and the right atria both will contract simultaneously. And this is because there is depolarization and that the electrolyte that they're using there is sodium. Now, there are valves here, and that prevents the conduction from going any further. All conduction must go through the AV node, which is this node we'll talk about in a little bit. The valves are very important because they prevent backflow. The purpose of contraction in the atria is to push blood into the ventricles, and then the valves close, preventing blood from coming back up, and also preventing electricity from going down other than through the atrioventricular node. So the only path down into the ventricle is through the AV node. So remember, since we have a direction of electricity going from sort of this position down to this position, if we put a positive electrode down here and a negative one up here, how is that going to look? It's going to look something like this. And so here we have our P wave, and you can see that the P wave starts at the very beginning of this first positive deflection and ends as soon as it comes back to baseline. That is known as the P wave. And we've already said what the P wave represents. It's atrial contraction from depolarization. Okay, next, AV node. The AV node, which sits right here, is the only pathway that allows electricity to go down to the ventricles. It is the gatekeeper. And it's very unusual in that it doesn't use sodium for influx, it uses calcium. And that means that it's going to be slower. Now, that's important because if we look at what's actually going on in the PQRS and T complex, what this is allowing us is the PR segment. And this allows the delay. This is the difference between the atria and the ventricle delay. And this allows the blood to go from the atria to the ventricle before the ventricle contracts. Okay? So this is calcium influx going on here. So we've got atrial contraction, then we have AV node, which is calcium, which is slow, which allows the blood to go from the atria to the ventricle through the AV nodes. On the right side, it's the tricuspid valve. On the left side, it's the mitral valve. And this gives the ventricle a larger size, which will increase preload, and we'll talk about that later as we go on to the next topic here. But we've talked about the P wave and now the PR segment. Next, let's talk about the QRS. So the next thing that's going to happen is you're going to get this His bundle, which is then going to conduct very quickly because it's using sodium channels now, and it's going to actually penetrate through that atrial ventricular insulation, and it's going to go down into the interventricular septum very quickly. So the His-Purkinje system, and remember these are modified myocytes, allows the electrical conduction or depolarization to move quickly to the entire myocardium almost simultaneously so that there is a coordinated contraction. And as it moves down, this His-Purkinje system here, so you got AV node, then you have the His, bundle of His, and then you have these bundle branches called the Purkinje fibers, as you'll see here. These Purkinje fibers are actually on the endocardium, and the direction of the electricity is actually, as we mentioned, out. So that's the direction of the positive charges that we'll talk about over and over again. Okay? Again, it's sodium, and it represents ventricular contraction. Let's quickly go over and see what that looks like over here. We've got the QRS complex. That first deflection down is known as a Q. The tippy top here is known as the R, and any downward deflection after an upward deflection is known as the S wave. And so what does the QRS wave represent? It represents ventricular depolarization and therefore ventricular contraction. We're not measuring here the electricity going down the His bundle, the bundle branches, and the Purkinje fibers. We're actually measuring the electrical depolarization of the ventricular myocardium. Now, I would be remiss if I didn't mention again that during this time, blood is being pumped out of the ventricles. On the right ventricle, it is being pumped out through the pulmonic valve, semilunar valve, into the pulmonary artery to the lungs to get oxygenated. And the left ventricle is pumping blood out of the aortic valve into the aorta to be distributed among the systemic vasculature. But at the same time that this is occurring, the atria, which depolarized way over here during the P and the PR interval, is now repolarizing. Now remember what that looks like. You've got cells where sodium has come in very quickly, and that's given a positive charge. What's now occurring is there's repolarization. Basically, that is accomplished by potassium leaving. Okay, and we'll talk about that in a little bit, but that causes a atrial repolarization here, but you cannot see it because it's buried in this huge QRS complex, so just be aware of that. Okay, so just as there is atrial repolarization, there is also ventricular repolarization, and that's going to occur right after this S segment here. And so what you get is you get the ST segment, which is a flat portion of the tracing. It should be right at baseline. It should be flat. If it is not flat, then you could have some serious problems, and we'll talk about that with myocardial infarctions later on. There could be ischemia or infarction of the myocardium. This is really where you're going to look. In fact, we divide myocardial infarctions on whether or not the ST segment is elevated or is not elevated. But you should know here that what's going on is repolarization. And then finally the T wave, where there is the greatest amount and something called rapid repolarization. So basically this is what's occurring in the atrium over here, but it's so large over here because there's so much more myocardium in the ventricles as compared to the atria. It's rapid, and again, what's going on here is you've got the cells, and what's happening is potassium is leaving the cells, and this is what is causing this rise in the T wave. And again, it is rapid. So the entire segment from the ST segment to the end of the T wave, repolarization is occurring, but rapid repolarization occurs here at the end of the curve. Now, you should know that this electrical conduction is occurring very quickly. You have depolarization of the ventricle starting here, and then repolarization occurring here. But you should know that it is through all of this that the actual muscle itself is contracting, and that's called systole. And in terms of what we were talking about before, again, we've got the quick depolarization occurring through the sodium channels, and then you have repolarization of the entire myocardium afterwards. Now, as we just said, the period of systole actually employs all the way here from the Q to the T. That brings up the issue of the QT interval, which is something that is seen quite often and which we'll talk about much more extensively later. You'll notice that the majority of the QT interval is made up of the time of repolarization. If someone's QT is too long, in other words, if the repolarization is taking too long to occur, the patient can be susceptible to getting very bad arrhythmias. And you can measure this. Now, the QT interval has to be corrected to how fast the rate of the heart rate is. And so what we do is we actually come up with something called the QT with a little c. That means it's corrected. We'll talk about how we get to that equation. But one of the things to know about is that you should very routinely be tracking patients who have prolonged QTCs, because there are certain medications like fluoroquinolones, amiodarone, azoles that can increase the length of the QTC and cause malignant arrhythmias. So this QT interval here, starting from this point to this point, is something that needs to be monitored very carefully, and you should be aware of this QT interval. Generally speaking, the rule of thumb is if you measure the distance from one R wave to the next R wave, this QT interval should be less than 50% of that. That's kind of the general rule of thumb. Okay, so our final thing on here is the U wave, which is a very minor wave and is sometimes actually not even seen at all. So you might not see it. The second thing is that if you do see it, it can be normal. The other thing it is associated with is low potassium. So just remember that. That's something that might test you on. It's thought to be related to the repolarization of the Purkinje fibers. There's a lot of debate about what it might be or might not be. And it also doesn't appear in some leads. So if you were to just completely forget about the U wave, that would probably be not too bad. However, the one thing that I would say that you should probably remember is this association with low potassium and U waves. Okay, so just to review real quick, P wave, atrial contraction, depolarization. PR segment is from the end of depolarization of the atria to the beginning of ventricular contraction. This PR segment is timed. Generally speaking, the PR interval, which is from the beginning of the P wave to the Q, should be no longer than 0.2. That's a 0.2 seconds. Remember, that's one big box. The QRS should not be any bigger than 0.12 or 120 milliseconds. And the QTC should really be no bigger than 440. Okay? Now, this distance of the PR segment here is how long of a delay is there between atrial and ventricular contraction. The longer the delay, up to a certain point, the more blood you can get into the ventricle. If there is not much delay, you're going to be having ventricular contraction as blood is still coming in from the atria. The QRS, obviously if this is very quick, then that means your bundles are working well. If the QRS is widened, you got to think about maybe a bundle branch block, because this is not allowing the depolarization to go down the His bundle very quickly. And then we talked about repolarization of the ventricle, and then of course the U wave and its association with hypokalemia. Okay, well, thanks for joining us, and join us for the next lecture.